Hello, and welcome to the 35th Bi-Monthly State Breastfeeding Coalition's webinar. This is Megan Renner from the United States Breastfeeding Committee, and I will be your moderator for today's call. As many of you know, the CDC Division of Nutrition, Physical Activity, and Obesity and the USBC co-host this series of webinars. If you are new to the webinars, though, we will let you know that these are held regularly every 2 months in the even-numbered months and on the second Tuesdays at 2 o'clock Eastern Time. So we also lovingly refer to them as the 222 calls, even month, second Tuesday at 2 o'clock. So if you hear that from time to time, that's what we're referring to. And the purpose of the webinars is to bring together the state, territorial, and tribal coalitions to share best practices and news and network and collaborate on issues of national significance in breastfeeding. I'm going to do a little bit of housekeeping here before we get started. Many of you also are familiar with the process for where you locate the webinar slides, and sometimes we have additional handouts posted. And you can also find archives of the past webinars on the USBC website. If you are connecting by webinar, there would have been a link in your confirmation email from the GoToWebinar system, and you can click that link or copy and paste it directly from that email. It will take you to the page with the slides and handouts. You can also go to our website, usbreastfeeding.org, and I'm going to show you a screenshot here of this quick links box over here on the right-hand side. Underneath there, you'll see a link for bi-monthly coalitions webinars, and that link is also there as a quick way to get to the information for these events. Just a quick announcement of how we will do questions and answers during these sessions. All of the attendees are in listen-only mode, and for the question and answer period, usually we do that at the end of the call. But you can submit questions at any time during the webinar by typing them into the questions box on your webinar control panel. And I'm going to show you what that looks like. For those who are logged in on the webinar, you'll have this GoToWebinar control panel, usually appearing on the right side of your computer screen. And underneath there should be a questions, the word questions with an arrow next to it. When you click on that question so that the arrow is pointing down, there will be a box where it says type question here, and you can type questions there again at any point during the webinar. You can also, a quick hint, this right side screenshot shows you there's this orange arrow, and if the control panel is getting in your way of viewing the slides, if you click that orange arrow, it will dock it over to the side of your screen and get it out of the way, and then you can just click the arrow again to bring it back out if you want to ask questions or look at the other controls. So just a quick screenshot of where to go for those functions. But without further ado, I'm going to go ahead and introduce our presenter today. We have Dr. Miriam Labbok from the Carolina Global Breastfeeding Institute presenting today. And the topic is on the Interstate Collaborative for Widespread Implementation of the 10 Steps to Successful Breastfeeding, sharing recommendations, next steps, and state action. In addition to her role as director of the Carolina Global Breastfeeding Institute, Dr. Labbok is a professor in the Department of Maternal and Child Health at the Gilling School of Global Public Health at University of North Carolina, Chapel Hill. As director of CGBI, the Carolina Global Breastfeeding Institute, the institute is dedicated to the 3 Bs: birth spacing, birth delay, birth practices, and breastfeeding. Previously, she served as the senior advisor for infant and young child feeding and care at UNICEF headquarters, where she was responsible for the revision and updates on the BFHI approach and materials. She also previously was the Chief of Maternal Health and Nutrition at USAID and the Director of Breastfeeding and Maternal Health at the Institute for Reproductive Health and Associate Professor at Georgetown University, and also formerly an Assistant Professor at Johns Hopkins School of Public Health. So without further ado, I'm going to go ahead and turn it over to Miriam, and just give me 1 second while I switch to her slides. All right, take it away, Miriam.
Good morning and good afternoon, everyone. I actually wish I could, in 20 minutes, fully explain all the wonderful things going on in the different states. But instead, let me present with you with a little bit of an overview of where the interstate collaboration came from and where it might be going. These stars show you the states that have been initially involved in this collaboration. Can you find your star there? Let's go on to the next. There we go. Emily Taylor, right in the middle there, is the project director for our work on the 10 steps. I'm the little chubby one to her side. But it's a team project. Everything we do here at CGBI doesn't get done unless everybody's on board. And we really are very excited to be involved with the 10 steps. Next, please. Okay. Today we're going to briefly review the 10 steps themselves. A little bit, not so much about implementation, but about the baby-friendly initiative and how it got started in the United States and beyond. Touch on the many wonderful state activities that are going on to support implementation. Give you a little bit of story about the Interstate Collaborative and some progress to date. And at the end of this, I hope we'll have time for questions, or if you have a question that doesn't get answered, please feel free to contact CGBI. You can just write an email to cbi@unc.edu for any further information. Next, please. For those of you who are not familiar with the 10 steps, I think it's really important that we know the steps as they're written and also be able to say them in our own parlance, if you will. So, for example, the first step is have a written breastfeeding policy that is routinely communicated to all healthcare staff. What that really means is that everybody needs to know about the breastfeeding policies of our institution, and of course that there are breastfeeding policies. The second is to train all healthcare staff in the skills necessary to implement this policy. Basically, that means that everybody has the skills to implement the policy. 3, inform all pregnant women about the benefits and management, and that is a pledge that you all have to make sure that there is unbiased information given out in a manner that women are actually educated about breastfeeding. Step 4 says help mothers initiate breastfeeding within 1 hour of birth. When we first wrote the 10 steps, we said within 1/2 hour of birth. If we were writing them today, we would probably say help mothers all start skin to skin as soon as possible and support the normal physiology that leads to breastfeeding. But that's a lot of words. So WHO has decided to keep the wording short. Number 5, WHO, by the way, is the World Health Organization. Number 5 is to show mothers how to breastfeed and how to maintain lactation even if they are separated from their infants. If we were writing this today, we would probably say something more along the lines of support moms as they learn how to breastfeed and as the mother and baby learn the breastfeeding dance, and teach them also how to express their own milk both for comfort and to maintain lactation. So you see, we've come a long way since these were originally written in 1989. Okay, let's go on to 6 through 10. Step 6 says give newborn infants no food or drink other than breast milk unless medically indicated. And what this means on the ground is that we don't give newborns foods or drinks other than human milk unless medically indicated. And we also respect the family's informed decision concerning this, because some families will choose not to breastfeed today in the United States, and we respect that. We also would like to give them all the unbiased information for them to make that decision. Step 7, practice rooming in. Moms and babies together 24 hours a day. That has to be supported. In reality, sometimes it's 22 hours instead of 24, but this is the goal. Step 8 is encouraging breastfeeding on demand. Unfortunately, the word demand is often misunderstood. What we really mean is that moms and families should understand the baby's hunger cues and fullness or satiety cues so that they can be responsive to the infant. So the infant begins talking to you from the second it's born. And it's important that we know the baby's language too. Step 9, give no pacifiers or artificial nipples to breastfeeding infants. And 10, foster the establishment of breastfeeding support groups and refer moms to them on discharge. Well, we aren't all doing that. Step 10 is perhaps the one we are lagging on the most in the United States. What this means is that every hospital is responsible for ensuring that there are breastfeeding support groups out there. Instead, we say, really, we'll help new moms get the support they need after leaving the hospital, which is a pretty good thing to do as well. So those are the 10 steps that have been around for quite a long time now. Why do we want to support the 10 steps anyway? Next page. Well, because they really work. When a country of Belarus was divided in half, and half the country's hospitals got the 10-step support, and the others got support as usual, what you saw was in the control group, those who got normal standard support, at 3 months, 6% or so were exclusively breastfeeding. Where there was baby-friendly hospital 3 months earlier, 43% were still exclusively breastfeeding at 3 months. A similar relationship was seen at 6 months, where the control group had virtually stopped exclusive breastfeeding, where 8% were still exclusively breastfeeding in the experimental group. Was this 100% success? Of course not, but this was what happens in real life when you institute a program in all the hospitals. And can you imagine going from 6% exclusive breastfeeding to 43% with a single intervention at the national level? Phenomenal. Next slide, please. Oh, could you just click again, please? There we go. Yes, I want the cover up, please. Go ahead and click it. Yay, there, that's what I wanted. Sorry about that slide, everybody. Basically, we did a study to see what would be the impact with not having all 10 steps in place, but what would happen if we were just working towards having all 10 steps in place. And we used the national data set to look at this, and what we found is that if only 3 to 4 steps were in place, moms were able to achieve their exclusive breastfeeding plans at about 45% among multips, and hardly anyone really among first-time moms. But with each 2 additional steps in place, you can see that multips reach much more success with even 5, 6, or 7 steps in place. But when you got up towards 7, 8, and 9, primips were doing just as well, almost as well, in achieving their exclusive breastfeeding plans. And this is very important because what this says is what we do in the hospital is vital. Even though a mom comes in knowing what she wants to do and leaves knowing what she wants to do, what we do in the hospital impacts on her ability to fulfill her plan. Next, please. So where did all this come from? In 1989, a group of us, many from the United States were involved in development of the 10 steps. Dr. Audrey Naylor was really the first person to become involved and is primarily responsible for what's in those 10 steps. And in 1989, we presented them at a meeting at Georgetown to the world, and they were very interested. The world was interested. In 1990, at the Interstate Meeting, some of you may know about the Interstate Declaration of 1990, the U.S. actually signed on and said we are going to implement the 10 steps in U.S. hospitals by 1995. Do I hear laughter in the distance? Well, it was a good goal, but it didn't happen. In 1991, UNICEF came back and said, come on, United States, please get going, and we had a launching at Georgetown. In 1992, the USA Committee for UNICEF helped launch the actual Baby-Friendly Hospital Initiative in the United States. What is the Baby-Friendly Hospital Initiative? The Baby-Friendly Hospital Initiative was launched by UNICEF as a way to designate which hospitals were practicing the 10 steps. It's a designation process, but we all know that if you get a star or a certificate for something, it is encouraging. So BFHI was developed to designate which hospitals had achieved the 10 steps. Today in the United States, we're doing pretty well. There's more than 152 countries around the world that have baby-friendly hospitals. About 28% of hospitals worldwide have ever been designated. However, in developed countries or industrialized countries like our own, it averages about 8.5%. How about in the United States? Here in the United States, up until a couple years, we had less than 3% of the hospitals designated. But we've had a little bit of a boom lately. And now it's a good 4% and growing. Next slide, please. This line shows the increase in baby-friendly designated hospitals in the United States that were designated by EBF USA. I stuck in what was going on worldwide so that you could compare. Around the world, there was a huge boom in the 1990s, going up to 19,000 worldwide. In the United States, we had a little bit of a slow start, and the total number of baby-friendly hospitals in 2002 was only about 25. What's happened is it continued at pretty much steady state, as you can see, until suddenly in 2006, 2007, things really began to take off. Those of you who are biologists know of something called the S-shaped curve, that things are slow to get started, but once you get past a certain point, they can really take off. And what was going on here were a series of catalysts going on that are beginning to take off now. One of which, of course, was Baby Friendly USA. But in addition, over the same time period, many states decided we're going to do something about this. And once the word spreads, it really gets going strongly. Next, please. So let's talk a minute about state-level activities. You know, we're kind of isolated in states. We get these federal mandates that come down on various things, and each state struggles to implement what comes its way. Some states are find it very easy to implement different things, especially where they're already the norm. Other states might struggle a little bit, and all of the states are all trying these days to figure out how to use the least possible resources to do the most in terms of services and project activities. Next, please. As a result, you know out there that many states have taken different approaches. One of the approaches was started in some of the smaller states, like Massachusetts, New York. Well, sorry, New York's pretty big. Sorry, Massachusetts, you're big too. But what was able to be done is that there was a summit, that all the hospitals came together, or most of the hospitals, and it was the decision makers from the hospitals who came together to hear about the 10 steps and what benefit they would do for the clientele, the patients, as well as for the institution itself. Other states took approach of providing technical assistance, and that's what we do here in North Carolina. Other states offered incentives, and the Texas, oh, I love the name, the Texas 10-step offers incentives for getting the steps into place. And what each of these did, oh, I shouldn't forget California, which frankly did everything. What each of these did was look at what was needed in their state, and each of these worked towards getting the ball rolling. Not saying, we're going to do 10 steps tomorrow, but what can we do now to work towards the 10 steps? I'm just going to read off some of the other names because I love them. Arizona Baby Steps, Colorado Can Do 5, Texas 10 Step, the Louisiana Gift, Guided Infant Feeding Techniques. Let me see what are other cute names. Baby Steps to Baby Friendly in Miami, and so on. If I missed yours, it's there are so many now. When we first started this effort, there were only 23 states that were even thinking about this. Since that time, at least 10 additional states have approached us to become involved. Next, please. So basically, the purpose, before I talk about the purpose of the meeting, about 8 years ago, we decided that we had to bring together all these different activities so people could learn from each other. And it took a while, and finally, just about 2 years ago, we were able to identify resources through AHRQ, the Agency for Healthcare Research and Quality. And after AHRQ funded the main conference, CDC and MCH also helped out with the conference. And the purpose of this meeting, this interstate meeting, was to let people talk to each other, to achieve greater understanding of current practices, what people were doing, Also, as it was part of our contract with AHRQ to develop a specific research agenda for further study, and also to produce and disseminate a summary report. This meeting was held last October, and my guess is that many of you online right now were there. Next, please. For this meeting, we used something that had been developed way back when for the Innocenti conference back in 1990. And what we called it was a working group process approach. It's an approach to help build consensus and collaboration. And it may seem pretty obvious. The first thing you do is you go to people who are going to be attending the conference and you gather some specific information on different issues. You summarize that, collate, interpret it, and share it back with the groups who are coming. Then from that base of material, you're able to figure out what are the areas that need discussion review and where do we need to innovate a bit, what happens when groups come together. After the meeting, we prepared a draft report. We disseminated it back out to the states for review. We then revised it, and we sent it out to some people who weren't at the meeting, a group of expert stakeholders for comment, and then it was finalized. Next, please. Just to share with you how the meeting went, it was extremely participatory. I have to say it was because of who was there. I wish I could say it was because of us. But the participants really dove in and did the exercises, built the consensus, shared what came out of their groups with great enthusiasm. This group was talking about engaging the state health department. Next, please. Some serious discussion was going on. You see Larry Grummer-Stroud there in the background, Marcia Balker, Roger is there. Oh, behind Roger is Barbara. Oh, I'm sorry, I forget your name, Barbara, if you're on the line, from New York State. I recently heard their program, and it is just going gangbusters. Next, please. A few more states we have represented here. California. You'll fill in if I'm forgetting who you are with California there. But in the background, we see some Colorado. Again, everybody working hard together. The states were represented, generally speaking, by somebody from the state health department, generally, not always, but sometimes the WIC representative, the head of WIC for breastfeeding, and somebody involved in the public sector, whoever were the main actors in the state. And we tried to get a mix of what you see here actually is somebody from the government, somebody from an NGO, and somebody from WIC. Next, please. With 23 states, we tried to keep it intimate. As you can see, my colleagues put a timer up for report outs and for discussion, so people were always aware of how much time they had for discussion. And I've never been at a conference, I must say, where people really tried very hard to get the full discussion done in the time allotted. Next, please. And it was fun, too, and we all got to get up there, vote, do our VIP process, argue with each other. Next, please. Report outs were really fun, and one of the concepts that came out of this was adopt a state, or two states partnering. And at first we were thinking, well, let's adopt a state like California would adopt a state that wasn't doing very well. But then we began to think that it might be better for states to adopt a state within their own region. When we looked across the country, we could not help but notice if you put in coloring for the level of breastfeeding, the southeast states remained the whitest, because there was the least breastfeeding going on. So what we decided is that the adopt a state would be more of a partnering state and be a state that's nearby you that would have similar background and similar issues. Next, please. And, of course, we had Melissa do her dance, her S2S dance, skin-to-skin dance, and rap, which I hope many of you have already heard online. Next, please. Okay, so the meeting report included a discussion of the real and perceived barriers to implementing in respective locations. And I should say we looked at it both at the hospital level and at the state level. So what we discussed were real and perceived barriers within hospitals and real and perceived barriers in the state helping the hospitals. So we took those two approaches throughout. And we looked at evidence-based solutions to the real and perceived barriers in the systems. We discussed the effective roles of government and civil society. It came out with recommendations for state-by-state adaptation to try to have more cost-effective and user-friendly implementation of the 10 steps. And we came up with a research agenda. I would like to underscore that this meeting was about supporting the 10 steps. Many of the hospitals that each state was supporting are interested and ready to go after baby-friendly designation. Other hospitals we supported are still a long way away from that. And so we really kept this meeting about helping hospitals to do the practices. And we were not talking about the national designation process, but we did talk about how these state processes were helping hospitals to get on board. Next, please. So in the short term, we had the meeting. Everybody enjoyed it. We all went home all enthused. Everybody was excited. But we really realized that for this to be useful, we had to turn this one-time successful meeting into an ongoing collaborative. And thank you very much to the W.K. Kellogg Foundation for feeling that this was an important new innovation. And they are now providing funds so that we can continue to define and increase the understanding at the state level, to advance adherence to the evidence base, and to increase the number and quality of studies that are out there. We are going to be posting all of this information very shortly on our website so that it will be available to all. And I'm sure that USBC will help us ensure that it gets out to everybody. Next, please. So basically, we had an October meeting that led to the collaborative approach. We do have the report drafted and it's been member checked. We do have a research agenda, and that has been vetted, and we're just getting it ready for dissemination. We are hopeful that some resources are going to come through to really allow us to develop an extranet that will be very easy for people to access. Next, please. How about the research agenda? Well, we came up with a research agenda about the length of the Magna Carta. So we've been working to bring it back down to those things that are actually doable. And we had a process by which everybody just looked at the research questions that came out and kind of rated them on criticality and doability. So we have that rating now, and with that we've been able to reduce it to a more manageable number of research issues that we will be sharing with you shortly. Next, please. Okay, so what's going to happen next? Well, within the next 2 quarters, starting this April, we will get these reports in a format that is accessible and readable by the public, as well after it's been given to all the members who are at the meeting. We are going to create the ongoing system of support for this state collaboration. We're going to have regular webinars, and we are going to improve our data handling and processing. Next, please. Next, please.
Sorry about that. You
no
want
problem.
To next one? Okay.
Yeah.
There we go.
We very much want this to be for and of the states. So we will be basically serving as, if you will, the oil to grease the wheels for states to talk to each other. We view our role very much as providing the fora, allowing the interchange. We will foster those adoptions and help people out. We've already started to develop a speakers bureau from those who are in the group. And we know we've already been approached, as I said, by several. I know that Arkansas and possibly Maryland, Arizona, many others are already asked to be an active part of this. And I would encourage you, if you think that your state level decision makers are ready to take on doing something active to support the 10 steps in hospitals, please consider joining us in this interstate 10-step activity. Next, please. Well, the next one really is just to say thank you. And I hope that we've achieved our objectives of reviewing the 10 steps in a manner that helps you remember where they came from and where we're going with them, what's been going on in the United States, how the states are actively working towards getting all 10 steps in place. And that action, working towards the 10 steps, is extremely important if we're going to get the designations increased around the country. You now know that there is indeed an interstate collaborative. Please, if you're not already involved in this, see if you can't get the excitement at the state level to support the 10 steps in hospitals. And I hope you've seen that we have a plan and we're ready to go on the next step. Thank you so much for your attention. I know it's hard to listen to a person do go on like this. I look forward to hearing your thoughts, and we at CGBI very much look forward to working with you in the future. Thank you very much.
Great. Thank you, Miriam. While I switch back over to the Q&A, do you want to just give that email address again for if folks have questions or they're interested where they should contact?
Yes, they can write to me directly. My email is labbok, it's my name, at unc.edu. Or you can write to CBI, Carolina Breastfeeding Institute, at unc.edu. Either one will work, and it'll get to the right person of our team to handle whatever your question may be. Thank you again.
Great. So I see we already have some questions coming in here. So I'm going to let a few more come in. And just repeat again, the screen that I'm showing right now shows you how to ask questions. If you go to your webinar control panel and click on that little arrow next to the word questions, it will pop up the box that says type question here. So please do go ahead and type your questions, and I will read them out to our presenter. Let's see. Getting a custom interested folks, so I will definitely share this contact information with you, Miriam. We have a question from, I believe, from Arkansas about pacifiers. Do you have a recommendation against breastfeeding infants sleeping with pacifiers?
The recommendation concerning pacifiers is considered controversial. However, the AAP does recommend pacifier use after a certain age. This is really not an issue for hospitals. In hospital, in the first 2 days of life, if a baby has a need to suckle, the best place to suckle is at the breast. If a baby is doing this behavior, that means they need your attention. Now, skin to skin can alleviate a lot of that need for comfort. There was a recent small study in which one hospital suddenly withdrew all the pacifiers, and they found that it actually led to less breastfeeding. How could this happen? Well, it happens because you can't withdraw one way of pacifying a child without giving another. So it's very important, if your hospital is considering taking away pacifiers, make sure your staff knows how to help everyone find other comforting techniques. And perhaps the best one is skin to skin. The babies love it. The dads love it. When you see a little baby holding onto those chest hairs, you just know it's right. So it's a very good way to comfort babies without a pacifier. So the rule to use a pacifier has to do later on. There was, again, just one study that showed that it was associated with less SIDS deaths when it was used after breastfeeding was well established. This has not been shown, by the way, in breastfeeding infants, but in formula-fed infants. I don't know if that answers your question.
Okay, thanks, Miriam. Well, if folks have additional questions, they can type back in. Here's a different one from Debbie Heffern. I'm very excited about this because I work in the flagship hospital of a 20-plus hospital chain. The response we continue to get on implementing changes is that anything we do has to go system-wide, and thus nothing gets done. Do you have any thoughts on that one?
Yeah, well, that is one of the things that's why we bring people together. In a situation like that, a summit-type approach might work. The CDC has now funded NICHQ to do a national project that's going to be supporting 100 hospitals, or 90-some hospitals around the country, to go through the steps to become baby-friendly. It might be good that if they would pilot at least one of the hospitals into that program, it could serve as a, if you will, a small test of change for all the other hospitals. Sometimes in those large systems, they won't do anything until everybody does it, but they are willing to try things out as long as that gets approval at the top. Now, for a system like that, that may be the best way to go. But that's without knowing your system, of course, I can't really go much beyond that suggestion.
Sure. Well, and you bring up the NICHQ Breastfed Beginnings projects. We have a couple of questions about the difference between the Interstate Collaborative and that one. Are they related in any way?
Well, yes, we work very closely together. In fact, the leadership of NICHQ was at the collaborative meeting, and we've been involved in the NICHQ decision-making meetings. However, there's a very real distinction. What NICHQ is about is helping 90 hospitals achieve a designation, the baby-friendly designation. What we are about in the collaborative is helping as many hospitals as possible to get on their way towards getting more and more steps in place through working at the state level. Now, is this, I hope it's not seen by anybody as a conflicting in any way. What we're trying to do with the collaborative is, if you will, catalyze hospitals to begin to think about this, to begin to get involved, to recognize after they've made 1 or 2 step changes, maybe we can go all the way for 10. What we've found is that some hospitals are daunted by the expense of going baby-friendly, by the fact that they have to have all these 10 steps in place. If you're on the baby-friendly listserv, you'll see that people are very worrying about, what about this one weird case or that one weird case? Will we not get designated because of that? The collaborative is about the state being supportive of the hospitals getting as many steps in place as possible. We are not going to designate you. We are not going to grade you in any way. We are about working with each state to figure out its own path for helping its hospitals. I welcome further questions about that if that's not clear.
Well, here's a related one that I think you may have just addressed by noting the distinction that NICHQ is working directly with the 90 hospitals, and the Interstate Collaborative is working with the state level. But the question was, do you need a letter of support from a state-level leader to sign on to the Interstate Collaborative or other documentation of the state leadership support?
Yes, in a word. Since the collaborative was just funded and we're just getting rolling on it, our first job is to get the website up, the extranet up, and so on. At the same time, we are welcoming groups approaching us. As I said, we've been approached by the health department in Arkansas. It's very important that the health department be involved. We think it's important that WIC be involved, and we think it's also important that either the coalition or whoever else in the state is working with hospitals be involved. And it may vary with your state. Here in North Carolina, the North Carolina Hospital Association is involved. So it really varies. The collaborative fully recognizes that each state has its own way of working and its own little powerhouse that might facilitate hospital change. And what we want to do is support those stakeholders, support them in any manner we can, because sometimes it's just easier when the support comes from outside the state for people to come together and get things rolling. So yes, indeed, if the people in your state, if it's obvious to you who they should be and they're on board, if you can get a little letter together from them saying we want to start this, and we are dedicated to working with the hospitals on the 10 steps, then please get in touch with us. Now, there's many groups, the coalitions, of course, work on everything. This is specifically on 10 steps. Right now, the 10 steps in the hospitals. I should say we also have 10 steps for child care facilities, and although that's not currently part of the coalition, if there's interest in that, it might be in the future.
Okay. Was the Indian Health Service or any tribal coalitions involved in the collaborative?
Yes, absolutely. The IHS was definitely invited, and they were coming to the meeting up until the very last second, and then they canceled. So what we are doing now is reaching out to many parts of the Indian Health Service just to make sure that they have the opportunity to be involved, because they are very interested. If somebody has an additional name to send us that they feel would serve that role in the Indian Health Service, I can tell you that centrally they're very supportive. It's just that they're working their bums off and haven't been able to get to a meeting doesn't mean that there's not interest. So yes, indeed, and we welcome additional names if you have them.
Okay. Let's see. I think this is
a
let me clarification.
Is everybody aware of what IHS is doing? This is tremendously important because in addition to what's going on at the state level in some cities, the Indian Health Service has decided, punto, all their hospitals are going to be baby-friendly. Now, what we've seen over the years, as you saw with the slow progress of implementation of designation over the years, it isn't that easy to go from nothing to being baby-friendly. It takes a lot of management decisions. It takes a lot of nursing decisions. It takes a lot of physician decisions. And these things deserve the respect that are necessary in order to make those changes. What is interesting about NICHQ is they're using a term I mentioned earlier, small tests of change, where they're supporting people to try something out, to see if it works in a small way, then to come back and discuss it. And this approach, the working group process, does the same thing. It allows for small tests of change. And what we're hoping to do is encouraging people to put their foot in the water, to try things out, and then get back together and see what worked and didn't work so that other people can learn from it.
Okay. Getting a bunch of questions. This is just a clarification on what you were talking about earlier with the state level leaders or decision makers being engaged. Which state decision makers, is there a requirement for a specific state decision maker to sign on?
We would like to see a representative from whether it's called the Department of Health or the Division of Public Health or whatever it's called in your state. We would like to see somebody from the government, somebody from WIC, and somebody from the private sector, the NGO sector, at least. But we're not limiting it. We just want to be sure that at least one stakeholder from each of those camps is involved. And you might ask, why do we do that? Because even if you go back to the Inocenti Declaration, even if you go back to the 1990s, it's always been recognized that change is facilitated when you have both government and civil society involved. And in our country, the biggest tranche of resources and organizational support for breastfeeding comes from WIC. That's why we are starting with at least somebody from each of those three.
Okay.
What do they have to be signing up to do? That's the other thing. I mean, it's not like they're signing their life away. This is a signing up that we are committed to doing, to actively supporting the 10 steps in our state. And we want to be part of a group that will help us see our way.
Gotcha. So here's an interesting question. Have you found that institutions going baby-friendly sometimes do not support their own breastfeeding employees? And perhaps do you think that employee breastfeeding policies should be included in the baby-friendly hospital step of educating all employees on breastfeeding policies? This particular institution is going baby-friendly, but breastfeeding employees seem to not be supported as well as they are supporting the patient.
Give that questioner a gold star. It's absolutely. Again, hospitals have to write their policies different ways, but it should be written into the policies that obviously you have to treat your personnel at least as well as you're treating your patients. Again, if I may throw in an international anecdote, when I was working in this field directly with hospitals, what we found is where the nurses were allowed to bring their babies in to the hospital, into a co-located daycare center, things went much faster. When the clientele could actually see that the nurses were, practicing what they preached, breastfeeding acceptance went much faster. So that is a very interesting question. I'm sorry to hear that that's happening. It is something that we are dealing with, and we're dealing right now with directly, not only indirectly through the state level, but we're dealing directly with 23 hospitals here in North Carolina, semi-directly or indirectly, and we have seen this addressed and not addressed, and it's a very important issue.
Oh, it looks like the person who just made this comment has just left, but I'm going to read it anyway. This was related to the question about having to go system-wide, and she says, When I asked to have alternative feeding policies for babies who were not latching on yet, I was concerned when my supervisor said I would need to get it in place at all the hospitals in our system. But as it turned out, it was easier to do this system-wide because the lactation consultants at the other hospitals had been working in the system longer than I had, and they knew how to get policies approved. So we were able very quickly to get alternative feeding methods in place at all of our hospitals. So that was just a comment.
Wonderful. And that's wonderful, and it reinforces that in these large systems where you have several involved, if you have one or two people who know what they're doing or who can make the change, who can contact the right person, it certainly can help the whole thing. But unfortunately, that's not always the case. And where it isn't, then sometimes what we have found is that you get permission up above to do a small experiment, and then you have the people who have seen what happens to say it's feasible. You basically build your stakeholder group in that manner. But that's wonderful news that happened there.
Yeah. Question, we are struggling with finding funding to support this effort. Do you have any specific ideas of who a coalition might approach?
To be part of the Interstate Collaborative, there is no particular funding, but there would have to be people designated to be contacts and to be involved. I don't know what they're looking for funding for, so it's a little hard to respond to that question. The funding for the baby-friendly hospital costs, I don't, you can approach MCH, you can try to be one of their hospitals. The funding to support hospitals changing their practices, this Interstate Collaborative that we're now starting, the only cost might be co-funding somebody to come to a meeting once every other year. But the rest of it would simply be working with others, using the exchange, feeding in, and hopefully people can find the time to do that. I'm smiling as I say that. I'm sure everybody on the phone is as well. Like, we all have spare time, right? But this is a way to really move forward breastfeeding. There is no question that what happens in the hospital affects women long-term in terms of their breastfeeding intention and success.
How do you see WIC's role, especially at the state and local level?
Well, WIC could be tremendously important. Again, it varies greatly from state to state. But if women were able to register for WIC in concert with prenatal care and hospital care, that connection of the support for breastfeeding after you have the baby and the support in the hospital would be clearer. Right now, many people still perceive of WIC as being a formula supply only. And we know on this phone, and anyone in WIC knows that WIC is now very much about breastfeeding support. So having WIC involved also makes sure that you get consistent messages out to clientele, even if you don't have the earlier registration. The other aspect is in many states now it is WIC who is providing pumps to women, low-wealth women, to continue breastfeeding after they continue milk expression after they go back to work. In some states it was Medicaid. Many of them are now handing this off to WIC. So we have a situation where WIC is becoming more and more responsible for lactation maintenance after return to work. Along with the ACA coming down the pike starting this August, that's going to ask for time for hourly workers if the Health Care Act. Anybody hear what the Supreme Court said today? They're supposed to be declared today. Well, okay, depending what the Supreme Court says, it may be that the law will say that women can express milk during the workday. And if that's the case, then the WIC will be playing a central role to the implementation of that law.
I'm going to take one more here, maybe two. We heard you mention that there are 10 steps for child care facilities. I think that this is new to some folks. Can you elaborate on that a little?
Yes, we developed and tested them here in North Carolina. There's at least 5 other states that have some kind of child care law or regulation that to protect breastfeeding and support breastfeeding. But what we were able to find funding to actually test an approach that has 10 steps. And North Carolina is about to launch that as a certification for child care facilities. We'd be happy. We're putting up a toolkit online even as we speak. I think Brooke Colgan might be on this call, is doing the final tweaks to get it up there, and we'll be happy to share the materials. And we can do the training of trainers for you, or you can do it yourself, but it was quite exciting, the impact we could have with just a 2-hour training of child care providers. And in most states, there are regular trainings demanded, so it fits right into the system. And we are quite excited about that as well. And you have the email, cbi@unc.edu, or my last name at unc.edu. And I will be passing some of the questions on to Emily Taylor, who was to have given this talk, and to Brooke Colgan, who I just mentioned, as well as the other rest of the team that you saw in that picture.
Yes, we will. We do have many questions often than we're able to answer on the call, so we will share these questions with Miriam and her team, and as well as how they can get in touch with you. And Miriam, it's correct to say that you will be sharing the final documents from. We had a couple of questions about how do they get the materials, and those will be distributed through the USBC Coalition's listserv. Is that correct?
I'm sure, again, I'm sorry Emily's not on this call. At first we will get it out to all the states who are involved, the 23 states, and as soon as it's 100% approved, it will be available on our website, and we can certainly get it to all the coalitions. As you know,
okay.
Megan, we work closely together with you.
Sure. So yeah, when it's able to be sent out to all, we'll send an alert out to the coalitions list. That would be great. So I'm just going to make a couple of quick announcements, especially about national breastfeeding. Oh, sorry.
Thank you. I just want to say thank you very much for handling the questions.
Yes, I'm sorry.
Thank you all for your interest in this subject matter.
Don't go away yet, but yes, thank you so much, Dr. Labbok. It was great to have you on the call, and we will, as I said, keep following up with some of the Q&A that we weren't able to get to. So a couple of our announcements are actually related to some of the questions that were brought up today. So I wanted to make sure we have a little bit of time to talk about these. As you know, you've seen this before. The conference is coming up in August at the Sheraton National Hotel. Similar schedule to before. This is not news, but I did want to just highlight, of course, the preliminary program and online registration have been up at the conference website for a couple of weeks now. We also have the pre-conference workshop registration open, and this is where the two offerings are directly related to some of the questions we had today. The first one, the half-day workshop, we do have a trainer from the Foundation Center coming in to do a half-day workshop, Introduction to Foundation and Corporate Fundraising. If you click on the website, you will see the expansive list of topics that they will be able to cover for us, and we will be surveying the registrants, the attendees that register for this, to also try to tailor it a little bit more to the level of expertise of the folks signing up. So this is something new. We've not been able to offer this type of fundraising training in the past, but we're very excited to have the Foundation Center come, and they really do have wonderful content that can be quite expensive to attend one-on-one. So this is a great opportunity. And then the second workshop, the full-day workshop, has taken a little bit of a longer time to evolve, and even just in this afternoon, we've been talking with CDC and Carthy from NICHQ, and then also with Emily and Miriam at CGBI a little bit about how this workshop will play out, because as you know, there are multiple initiatives going on across the country with maternity care practices. Of course, we've heard about, we've been talking about several of them already today, and this workshop will be a full day and will include representatives from all of those different initiatives, also from some state coalitions. We'll be hearing from some state examples, as well as from Trish McEnroe at Baby Friendly USA. So this is another a great opportunity for some more intense time with these issues, and as people are asking, how do all of these fit together? That's one of the things that we'll be talking about with this workshop, and also talking about how the coalitions can fit in and can get involved, regardless of whether you already have been involved, and regardless of whether you have hospitals in your state that have been selected for the NICHQ project. This workshop is for you. So do check that out on the conference website. I also just want to have a quick announcement about our plans for National Breastfeeding Month. As you know, last year, USBC officially proclaimed that the entire month of August is henceforth National Breastfeeding Month. And we have some exciting plans for this year. Not only is it the conference, but we're also going to be launching a social media campaign in celebration of the month, and it will be called 20 Actions in 20 Days and focused on the Surgeon General's quote, "Everyone can help make breastfeeding easier." So each weekday, starting on August 6th, which is the last day of the conference, and incidentally, we will have had a social media plenary session at the conference to help us also prepare for this. But starting on Monday, August 6th, and going through the 31st, each weekday will be assigned to one of the 20 actions. We will have a lot of information up on this webpage here, which I've noted here will be going live on June 20th. There will be Twitter hashtags to link everything together. We will have sample tweets and sample posts for you, as well as a variety of different tips and tools to get involved at a bunch of different levels. We wanted to have both sort of beginner level social media, intermediate, and advanced, and you will have different suggestions for how you can get involved in this campaign, regardless of how experienced you already are with social media. So we're very excited about this. The only reason it's not live today is that we have our media PR committee call next week, so we need to finalize those hashtags and the calendar, the schedule of how the actions will be scheduled across those days. So we will have that up on that link, so do check that out, and we'll have email announcements going out as well. And then on the advocacy side for August, as you know, we have the advocacy of the lobby day that happens at the end of the conference, where attendees in DC can go to the Hill on Monday. That is, of course, still happening, but we also will be offering the opportunity and encouraging a virtual advocacy day. We will be having the trainings offered by webinar in advance of the conference. The materials will all be posted online, and we really want to encourage folks, whether you're coming to DC or not, and also to encourage your members, other advocates, moms, grassroots folks in your state to use these tools, attend the trainings, check out the materials, and be visiting their legislators during the month of August and beyond. Really, this is something that we can all do, and USBC is really excited to have some additional resources to ramp up our support efforts in this area. So I also have posted a link here. This is the link to the Advocacy HQ on our website, which you will see has information all the time, but we will have the Advocacy Day training date up on June 20th as well. We actually have a committee call tomorrow to finalize some of the details for that. And just as an aside, I also will note that we are very closely watching the Supreme Court, and our advocacy committee, as I said, is meeting tomorrow, and we'll be discussing and just planning for what may or may not happen with that. But we are thinking about it, and we'll be in touch with you as these things play out. So. So finally, I know we're a little bit late. Just want to have a quick reminder: if you are one of the 5 folks connecting to your state, or connecting to the regional calls for your state, and you would have received that call-in information from your state proctor, you will need to disconnect at this time and dial into the regional number. Also, just a reminder for everyone, please do submit an evaluation for today's session, and that link is on the web page with the handouts that we discussed earlier. And you'll also get a follow-up email just in about an hour with a reminder of that link as well. The system does that automatically. So thank you again, Miriam.
Megan,
Thank you.
this is Pat from CDC, and I have a few CDC announcements if there's time.
Oh, sure. I'm sorry. I didn't realize you had it. Okay.
I'm sorry. Well, we didn't, but they're late breaking. So first was I wanted to let folks know that we have indeed selected the 90 hospitals for the NICHQ project, which is very exciting. We'll be announcing them individually next week, but the hospitals that were selected have already, I know, started telling people. So so if you know them, you can talk with them. But we selected 90. We're really, really happy with the applications that came in. We got 235 applications from 43 states, and the 90 that were selected are from 29 different states. And those states represent the states with the lowest initiation and exclusivity rates and the 10 highest 2-day supplementation rates. They also cover 275,000 babies, so that's pretty exciting. 15 of those hospitals have at least half of their mothers are non-Hispanic Black, and 2/3 of those that were selected have at least half of their population is Medicaid, and all of the hospitals that were selected have at least 20% of their population was Medicaid. So we're really going to be able to make a tremendous difference, and we're very excited about that. So yay, it's getting concrete. Also wanted to let you know that we have put the benchmark reports for the 2011 MPINC surveys into clearance. So now it's the lovely government game of hurry up and wait. So they're moving away or along. And we are working to get the state reports into clearance as soon as possible, so quick on the heels. But we will be releasing sending out the benchmark reports before the state reports. So those are the two big things. Just want to make sure people knew because it's very exciting. So we've been working on those things for a long time. That's all.
Wonderful. Thanks, Kat. Well, again, if you're continuing on to the regional call, you will need to hang up and call back into the regional number. And then for everyone else, we thank you so much for participating today, and we'll look forward to seeing you in August. Thanks so much, everyone. Take care.
Thank you.